Discuss the classification, clinical features, diagnosis, and management of hemolytic anemias. Anemia resulting from increased red cells destruction is called as a hemolytic anemia. Hemolysis can be defined as shortening of RBC survival to less than 100 days. Normal is 120 days. Normal marrow has tremendous capacity to compensate for hemolysis, hence anemia occurs only when compensation is not adequate. Hemolysis may be an extravascular or intravascular phenomenon. Autoimmune hemolytic anemia, that is AIHA, and hereditary spherocytosis are examples of extravascular hemolysis because the RBCs are destroyed in the spleen and the other reticuloendothelial tissues. Others are due to intravascular hemolysis. Coming to the classification of hemolytic anemias, which are broadly classified into two types, hereditary and acquired. First one, hereditary, which include membranous defects such as spherocytosis, elliptocytosis, spur cell anemia. Enzyme defects, which include G6PD deficiency, pyruvate kinase deficiency. Hemoglobin defects such as thalassemia and sickle cell anemia. Second one is acquired, which includes paroxysmal nocturnal hemoglobinuria, which is PNH, immune mediated such as autoimmune hemolytic anemia, incompatible blood transfusion, mechanical, which include prosthetic heart valves, March hemoglobinuria, drugs which are dapsone and primaquine, infections such as malaria. Coming to the clinical features, in the history, patient may complain of fatigue and other symptoms of anemia. Mild jaundice, that is lemon yellow. History of passing red-brown urine due to the hemoglobinuria. Left hypochondrial pain due to splenomegaly. Right hypochondrial pain due to the cholelithiasis. Pigment stones occur due to the increased production of bilirubin from hemolysis. Family history may be present in the hereditary hemolytic anemia. Drug history may be positive. Symptoms of any underlying disease responsible for hemolysis. Physical findings include anemia, mild jaundice, splenomegaly, hemolytic facies due to the marrow hyperplasia in skull bones and other bones, ankle ulcers seen in sickle cell anemia, signs of any underlying disease responsible for hemolysis. Investigations. Evidence of increased RBC destructions are indirect hyperbilirubinemia, usually less than 5 mg per deciliter, increased urobilinogen excretion in urine, decreased plasma haptoglobin and hemopaxin, increased plasma lactate dehydrogenase, that is LDH, shortened RBC survival as demonstrated by chromium 51 labeled RBCs. Evidence of increased RBC production are increased reticulocyte count, that is reticulocytosis, finding premature RBCs in peripheral smear, that are macrocytes, polychromasia, nucleated RBCs, erythroid hyperplasia of bone marrow. Additional findings in intravascular hemolysis are hemoglobinuria, hemosideриnuria. Tests to diagnose underlying cause of hemolysis are peripheral blood smear examination, Coombs test to detect the antibodies causing hemolysis, hemoglobin electrophoresis for thalassemia, osmotic fragility, sucrose lysis, and Ham's test for membrane defects. Measurement of enzyme activity such as G6PD, pyruvate kinase. Other tests are done depending on the suspected underlying cause. Coming to the treatment, we can give supportive therapy or specific therapy. In supportive therapy, we'll give blood transfusion for severe anemia, replacement of vitamins due to increased erythropoiesis for iron and folic acid, treatment of infections, treatment of ankle ulcers, splenectomy in selected cases. Coming to the specific therapy, This depends on the underlying cause: steroids for immune hemolytic anemia, splenectomy in sickle cell anemia, and hereditary spherocytosis, withdrawal of offending drugs, and etc.